Welcome, everybody, to the CPAC meeting on oviparexton for narcolepsy. At the beginning of every CPAC meeting, we want to ensure that all speakers disclose any financial relationships with industry. Every member of our CPAC panel who's present today has met the ICER conflict of interest policy. So I'll call on each CPAC member to introduce themselves and to note whether they have any updates to this declaration. I'll start with those who I see on my screen. Kurt, you're first.
Good morning. I'm Kurt Vandenbosch. I'm a pharmacist with the St. Luke's Health System in Idaho, and no conflicts of interest to report.
And now, seeing the slide, I'm happy to go alphabetically. Eric. Oh, I'm not sure if Eric has stepped away for a moment. Bijan?
Hi, I'm Bijan Bora. I'm a professor of health services research at the Mayo Clinic College of Medicine, and I have no conflict of interest to report. Thank you.
Thank you, Bijan. Don? Don may need a moment to rejoin us. Ingba?
Yeah, hi, I'm Ingve Falketer. Thanks for having me. Yeah, I'm a professor at Case Western Reserve University in Cleveland, and I have no conflicts to disclose.
Thank you. Jayani?
Hi, I'm Jani Jawardhan. I'm an associate professor in the College of Public Health at University of Kentucky. I have no updates to the conflicts of interest. Thanks.
Thank you. Jill?
Hi, I'm Jill Johnson. I'm a professor and clinical pharmacist at the University of Arkansas for Medical Sciences, and I have no updates to my conflict of interest statement.
Thank you. Brad?
Good morning, everyone. I'm Brad Martin, professor in the Division of Pharmaceutical Evaluation and Policy. I have no updates to my conflict.
Tim?
Hello, I'm Timothy McBride, and I'm the professor in the newly named Bursky School of Public Health as of yesterday. I have no additional conflicts to add, and no
Wonderful.
conflicts at all.
Reem?
Hi, everyone. Reem Mustafa. I'm a professor of medicine and nephrology at the University of Kansas, and I also direct the Evidence-Based Practice and Impact Center, and I have no updates to my conflict of interest.
Thank you. Jimmy? Jimmy, I'm sorry, we're having trouble hearing you, or at least I am. I can see you speaking, but unfortunately I'm having trouble. So if other ICER team members are as well, we'll come back to you. Stuart?
It's better.
Oh yes, perfect.
Hi,
Yes.
my name is Jimmy O'Hare. I am a patient advocate and I have no updates to my conflict.
Thank you very much. Stuart?
I'm a clinically retired cardiac electrophysiologist, most recently working as the lead patient experience consultant for a large Trinity-based multi-specialty group in southeastern Michigan, and I have no updates to my conflicts of interest.
Thank you. And I see Don has included his information in the chat. I'm Rachel Sachs. I'm a law professor here at Washington University in St. Louis, and I have no additional conflicts of interest to discuss. With that, I would love to call.
Rachel, did we get Kurt?
Yes, I began with Kurt. Very out of
did.
order. I apologize.
Oh, that's right. You did it out of order, and I'm not paying enough attention. Sorry.
So I'd love to have a chance to call on our additional individual patient and clinical experts who are joining us today to introduce themselves and declare any potential conflicts they may have. Tammy?
Thank you, Tammy Anderson. I'm the executive director of Wake Up Narcolepsy, a nonprofit organization dedicated to driving narcolepsy awareness, education, and research towards improved treatments and a cure. My almost 20-year-old daughter was diagnosed with narcolepsy type 1 10 years ago, and I have no additional disclosures. Thank you for having me.
Thank you, Tammy. We're so glad you're here. Emily?
Hello, nice to be here. My name is Emily Clegg Barker. I am a person living with narcolepsy. I was diagnosed about 20 years ago. Relevant background includes I studied chemistry and did basic research and also do a lot of writing in pharmaceutical drug development. I'm very involved as a patient advocate. So tuned into patient needs. Also, I was a participant on the phase 3 clinical trial for oveporexton, and so I'm looking forward to sharing my experiences today.
Thank you, Emily. I'm looking forward to hearing your perspective. Dr. Ortiz?
Hi, my name is Louis Ortiz. I'm a assistant professor of pediatrics at Johns Hopkins School of Medicine, and I practice as a sleep medicine physician at Johns Hopkins All Children's Hospital in St. Petersburg, Florida. I also have type 1 narcolepsy, and I've had experienced that since about the age of somewhere between 10 and 12 years of age. And I'm very happy to lend my expertise to this discussion.
Thank you so much. Dr. Scammell?
Yeah, I'm Tom Scammell. I'm a professor of neurology and sleep medicine at Harvard Medical School. I practice at Beth Israel Deaconess Medical Center. My clinic is very skewed towards people with hypersomnia disorders such as narcolepsy, and I do basic research on what goes wrong in the brain in narcolepsy and how the meds that we're using now and in the future help make those symptoms better. And as you can see, I have a number of conflicts down there. I consulted with Takeda, which is particularly relevant for today's discussion. No other new disclosures.
Thank you so much. As we go through the rest of the meeting, all other speakers, including participants in the policy roundtable, individuals making public comments, should also announce any financial relationships with industry or other potential influences on their judgment when it's their turn to speak. So with that, I'll introduce Sarah Iman, the President and CEO of ICER.
Rachel, thank you. And thank you for everyone who's joining us today. It's my pleasure to be joined with my esteemed colleagues. You'll hear from Felucio Agbula, who's our Senior Vice President of Research, who served as the senior management team lead for this review. Dr. Grace Lynn, the evidence author, who's our medical director for HTA and also practicing physician at UCSF, as well as Linda Liu, who is the lead modeler and is a research scientist at the University of Washington. Deeply honored to have such an esteemed group joining us today to talk with all of you, who are also quite esteemed, about this new treatment. Next slide, please. What we want to do is make sure that we're centering the entire point of being here, which is there is a potential new treatment for narcolepsy type 1. We heard this story from a patient when we distributed our Share Your Story form to the patient community. Imagine living 72 hours without sleep, and the rest of the world still expects you to perform as if you got 8 hours of sleep. That is what living with narcolepsy is like. There's never a moment when I feel fully awake or alert. My daily life revolves around managing my symptoms. It requires so much physical and emotional energy that I've had to reconsider what responsibilities I can realistically take on. While many of my friends are starting families, I have chosen not to have children. I am deeply touched by this story that is shared for the multitude of impacts that this condition has, not just disrupted sleep. What is it also doing to the quality of life of people living with narcolepsy type 1? Next slide. So when we have this situation, why are we here today? When we have the potential for a new therapy, we have questions that we still need to answer once they are approved. There are questions about the risks, the benefits. How do these treatments fit into the evolving landscape of treatment? What are reasonable prices and costs to patients, the health system, and to the government? And what lessons are being learned to guide what we do in the future? We might all think that everything sort of ends with FDA approval, but the way we look at it, that's when things begin. Because if we care about affordable access for new therapies, we have these important questions that we need to answer. That's one of the reasons we're having this convening today. Next slide. And I do want to remind everybody that the context within which we are working is not just about this medicine. The affordability crisis of healthcare is real. I doubt there is anyone listening today or participating in this meeting that has not had this impact them, their families, their patients, their friends. We are at crisis mode, and I just want to make sure that when we are talking about the risks, the benefits, the costs, the value of a new medicine, we have it in the context of more and more Americans reporting that they cannot afford healthcare. 1 in 4 employers saying that they are not able to absorb the increasing costs of offering health insurance, and they're doing things like reducing spending on other benefits. slowing wage increases for employees, increasing prices for their products and services, and laying off staff in order to accommodate higher costs. Couple that with choices individual patients that are making to not pay for health insurance because they're young, they're healthy, and they feel like they can spend that $1,000 that they would have to spend on their premiums somewhere else. Guess what that does? That puts even more pressure on the system as people leave the health insurance system. And so I bring this up so that as we have the conversation today, we do not forget the impact that every choice about price has on the affordability of health insurance and healthcare for everyone in our system. Next slide. Because we can do two things at once. We can hold the patient, their family with narcolepsy type 1 in front of us and want them to have affordable access to new therapies. And we can also make sure that we are centering the experience of other people in the healthcare system so that they and their families continue to have affordable access. Next slide. We're ICER. We're an independent nonprofit that exists to foster these types of conversations based on evidence. We completed an evidence review that includes comparative clinical effectiveness as well as cost effectiveness analysis to inform conversations about price and access. Our Midwest CEPAC, who you just met, are independent of us. They are experts in clinical medicine, in economics, in patient and consumer advocacy. They will be asking questions about our evidence report, and they will be asking questions of our patient representatives and our clinical experts to help get the best possible picture we can about the role of this new therapy in our system. Next slide. I have no additional conflicts to offer up. That was Rachel told me I was supposed to start with that, but I do want to make sure that everyone has access to where we do list all of our funding. Every organization that has given us money over the last 12 months is listed on our website. All of our research is supported by independent nonprofit foundations and individual philanthropy. Any money that we do get from manufacturers, health plans, pharmacy benefit managers supports policy leadership activities through our policy leadership forum. Next slide. So how did we get here? It's been about 8 months. And so this process starts by asking patients and clinicians and the manufacturer, what are the big questions we should answer in a comparative effectiveness review? We then developed the evidence report and the model with our partners, Dr. Lynn at UCSF and Linda and Dr. Josh Carlson at the University of Washington. We put it up for public comment, received those comments, but also received feedback from expert reviewers who are listed here. When we put up that revision, that forms the basis of the conversation today. And when we close today, we'll talk about the timeline to finish this report, which will be reflective of today's deliberation, votes, and policy roundtable conversation. Next slide. We're going to talk about value a lot today. And so a very quick primer on what we mean when we talk about value. We talk about things represented here in green, which are most of the time easy enough to measure. Is a new drug helping patients live longer if it's a life-limiting condition? Is it helping them feel better, get back to their activities of daily living? Is it impacting the people in their lives, the caregivers? Is it impacting their ability to get back to work? Is it saving money for the system? How much money are we adding to the system for a new therapy? But we don't want to shy away from things that are harder to quantify, but still terribly important as we think about comparative value represented in the blue boxes. Benefits beyond health and special ethical priorities are why we have a public conversation about a new therapy, because there is context here that's really important. And you'll see in our voting questions how we try to elicit feedback from the Independent Appraisal Committee on what those priorities and benefits beyond health are, so that ultimately decision makers have the best sense of the condition, the role in therapy of the new intervention, and what represents good value for both patients and the healthcare system. Next slide. You've made it through the opening. We are about to hand it off to Dr. Grace Lynn, who will walk us through the clinical evidence, followed by the presentation of the economic model. We are thrilled that Takeda, the manufacturer of oveporexton, is here today to also give us direct feedback on that economic model. We'll have some public comment from patients and the manufacturers, followed by a lunch break. When we get back from lunch, the Midwest CPAC will deliberate and vote on the different questions that we have put forth. Those questions are also available on our website in conjunction with the evidence report if anyone wants to follow along. After a break, I'll come back to moderate a conversation with the clinical experts, the patients, the manufacturer, as well as representatives from the payer community about what do we do now? How do we use evidence to inform policies that center patient and system affordability and access? After we close with some reflections from the Midwest CPAC, we will wrap up around 4 o'clock Central Time. With that, it's my deep pleasure to invite Grace Lynn to the Zoom to take over the presentation of the clinical evidence. Thank you, Grace.
Thank you, Sarah. Hello, everyone. As Sarah said, I'm Grace Lynn. I'm the Medical Director for Health Technology Assessment at ICER. I'm also a Professor of Medicine and Health Policy at the University of California, San Francisco. Next slide, please. On the clinical team, I'm joined by Dimitri Nidikin and Sol Sanchez, both research team at ICER, and these are our disclosures. Next slide, please. So today we will be talking about narcolepsy, which is a chronic neurological disorder characterized by the brain's inability to regulate the sleep-wake cycle. So there are rapid shifts between sleep and wakefulness. This disorder affects approximately 1 in 2,000 people, so it's fairly rare. It appears to affect males and females equally. It typically starts in adolescence or young adulthood and is a lifelong disorder. There are 2 types of narcolepsy type 1 or NT1, which is characterized by the loss of orexin-producing neurons in the hypothalamus and therefore causes low orexin levels in the cerebrospinal fluid or the CSF. There's also narcolepsy type 2, which we don't know what causes NT2. These patients have normal orexin levels. Today, we're going to focus on narcolepsy type 1. Next slide, please. So symptoms of NT1 include excessive daytime sleepiness. So this is an uncontrollable urge to sleep during the day, even if one has gotten adequate nighttime rest. It results in daytime sleep attacks where people fall asleep suddenly. But not only are people living with narcolepsy sleepy during the daytime, they also don't sleep well at night. Narcolepsy causes fragmented nighttime sleep and sleep paralysis, which is the paralysis is being unable to speak or move when waking up at night. People with living with NT1 also have cataplexy. Cataplexy is the sudden loss of muscle control, usually in response to intense emotions such as laughter or excitement, or maybe a negative emotion like anger. It can range from subtle signs like facial drooping to full body collapse. It can last from seconds to minutes. There's also variation in how often it happens. Some people have cataplexy happen, less than once a year, very rarely, and others have episodes several times a day. People living with narcolepsy can also experience vivid hallucinations as they are going to sleep or waking up from sleep. And they also describe cognitive impairment or what people say is brain fog. Next slide, please. The diagnosis of NT1 is established by a history of 3 months or more of excessive daytime sleepiness, or EDS, and at least one of the following: cataplexy, low orexin levels in the cerebrospinal fluid, or an abnormal multiple sleep latency test. The MSLT is a sleep study whose purpose is to measure how quickly a person falls asleep during some scheduled daytime naps during the test. The narcolepsy NT1 is also strongly associated with a human leukocyte antigen allele, this HLA-DQB allele. So a positive blood test can support diagnosis, but it's not diagnostic because about 25% of the general population has this allele, and not all of those people have narcolepsy. One of the things that we heard from both our clinical experts and patients is that the diagnosis can be delayed for years because, those symptoms are chalked up to, oh, you didn't get enough sleep, or life, you have too many things going on in your life. And usually people require a specialist like a neurologist or a pulmonologist specializing in sleep medicine to get that diagnosis. Next slide, please. There aren't any current treatments that address the underlying cause of NT1. Right now, the standard of care is non-pharmacologic treatment like daytime naps and a consistent sleep schedule. And then medications to promote wakefulness, like modafinil and methylphenidate, that address excessive daytime sleepiness, but don't address cataplexy. An anti-cataplexy agent and commonly used are antidepressants such as venlafaxine. And then sometimes there are agents that address both EDS and cataplexy, like sodium oxybate and pitolisant. Within this space, polypharmacy is common, and cycling between medications is also common. And so even with combination therapy, most people living with NT1 are not satisfied with their current treatment. Next slide, please. We want to express our gratitude for the engagement of the narcolepsy community to help deepen our understanding of what it's like to live with this disorder. We both interviewed patients and received feedback via ICER's Share Your Story portal, as Sarah shared the quote from one of the stories we received. This is a brief summary of some of the things we heard, but we heard a lot more about living with narcolepsy, and I'd encourage you to read the patient insights section in the report and supplement for much more detail on what it's like to live with narcolepsy. So the symptoms of narcolepsy affect all aspects of daily life, work, education, household tasks, grocery shopping, family planning, and it decreases quality of life, increasing rates of anxiety, depression, and social anxiety. We heard that cataplexy episodes can be embarrassing, particularly, and they're unpredictable. So even though people try to avoid situations where they might have a cataplexy attack, that isn't always possible. Again, diagnosis is often delayed, and specialists are hard to find, especially if you live in a rural area. This disorder has a large impact on caregivers. The diagnosis is often in young adulthood, and people with severe symptoms have difficulty with life tasks and with they aren't able to support themselves financially because they aren't able to work full time. Since current treatment usually involves multiple medications, there can be some challenges there. Again, a lot of this population are young adults. College can be a particular challenge since some of the treatments are controlled substances, and so they aren't, for example, oxybates there's no secure place if you live in a dorm to keep your oxybate, so you might not be able to be on that drug. We also heard that insurance coverage is a problem. Treatment is very individualized, and people may need to switch medications as the efficacy of certain medications decrease. So step therapy policies, for example, can be challenging to navigate. Next slide, please. So I'm going to go over the evidence for oveporexton. Oveporexton is a first-in-class selective orexin receptor 2 agonist. It's an oral medication. In the clinical trial, it was tested at 1 or 2 milligrams twice daily. And a new drug application was submitted to the FDA in February of 2026, and we expect a decision sometime in the third quarter of 2026. Next slide, please. So we'll examine the clinical effectiveness and safety of oveporexton as monotherapy for the treatment of adults with NT1 compared to no pharmacologic treatment, which is represented by the placebo arms evaluated in clinical trials, combination therapy of modafinil or armodafinil with venlafaxine, which we considered to be a representative comparator for concurrent use of a wake-promoting and anti-cataplexy agent, sodium oxybate monotherapy, and pitolisant monotherapy. Next slide, please. Our outcomes of interest are measures of daytime symptoms, such as the Epworth Sleepiness Scale, which is a subjective measure of daytime sleepiness, the Maintenance of Wakefulness Test, and cataplexy events. Also nighttime symptoms like sleep paralysis and hallucinations, work or school performance, quality of life measures, and adverse events, including discontinuation. Next slide, please. Next slide. So the key clinical trials for oveporexton are 2 phase 3 randomized controlled trials called First Light and Radiant Light, and 1 phase 2 trial, all enrolling patients with NT1. There were approximately 100 patients in each phase 3 trial. And in the phase 3 trial, the baseline mean Epworth Sleepiness Scale score was 17 to 19. Just for context, normal is less than 10, and a score of 17 to 19 would represent severe excessive daytime sleepiness. The baseline mean MWT was 4 to 6 minutes. For this test, the time to fall asleep of less than 8 minutes is considered excessive sleepiness. And people participating in the trial had a baseline mean weekly cataplexy rate of 11 to 27 events. Next slide, please. So we did a meta-analysis of the phase 3 trials, and what we found for the primary outcome of MWT, this is the mean difference versus placebo of almost 20 minutes. A clinically meaningful difference on the MWT is a change in 2 minutes. So there was a fairly large change in the MWT. For ESS, the mean difference versus placebo was almost 10 points. And a clinically meaningful difference is 2 to 3 points. The baseline, as you'll remember, was 17 to 19. So this is about a 50% decrease in the ESS. And treatment responsiveness, which is an ESS defined as an ESS less than or equal to 10, the oveporexton group was 5.6 times more likely to reach that ESS of less than 10. Long-term extension from the phase 2 trial showed that the effects were durable for at least 6 months. Next slide, please. We also examined cataplexy and other patient-important outcomes. Oveporexton decreased weekly cataplexy rates by a substantial amount compared with placebo, and also resulted in clinically significant improvement in this combined outcome of daytime sleepiness, cataplexy, hallucinations, and nighttime sleep. It also improved memory and cognition and improved health-related quality of life. Next slide, please. We know that people living with narcolepsy are usually on pharmacologic treatment. So we did a network meta-analysis comparing oveporexton versus active comparators. We looked at 13 trials, which included modafinil and armodafinil, sodium oxybate products, pitolisant, and oveporexton. Just as a quick note on the sodium oxybate products, we combined data from the also for all forms of sodium oxybate due to similar efficacy for the primary outcome. I will note that the 5 trials that we included are all from the high sodium oxybate forms. The trial follow-up ranged from 4 to 13 weeks. Next slide, please. So our first outcome from the NMA was maintenance of wakefulness. And this is, again, how many minutes can one stay awake? And you can see here in this that to the left, you'll see the oveporexton, and to the right, you'll see the comparators. And you'll see that oveporexton had a difference in the mean maintenance of wakefulness test of between 15 and 20 minutes compared to all other comparators. And recall that 2 minutes is kind of the clinically meaningful difference here. Next slide, please. This is oveporexton versus the other comparators on the Epworth Sleepiness Scale. This forest plot shows that oveporexton, again, had about 10-point difference versus somewhere between 2.5 and 3.5, 3.25 points for the active comparators of modafinil, pitolisant, and sodium oxybate. Next slide, please. Some limitations of comparisons versus active treatment. So again, we grouped together the sodium oxybate, and the data comes from higher sodium forms. We weren't, because of differences in the way cataplexy was measured in the trials, we weren't able to compare on cataplexy and other patient-important outcomes. Some of the older studies of the active comparators included both NT1 and NT2 patients. And there were some different trial protocols. We had some washout versus withdrawal studies, some differences in the MWT protocols that introduced some uncertainty into our NMA results. Next slide, please. Here's an overview of key harms for oveporexton. There was a pool safety review of oveporexton trials that showed the drug was well tolerated. The most common adverse events were frequent urination and insomnia, but these didn't seem to cause people to discontinue the drug, as the discontinuation rate was about 2.6%, and there were low rates of serious adverse event at 1%. An earlier version of orexin receptor 2 drug showed evidence of drug-induced liver injury. Oveporexton is a more specific to the orexin receptor 2 receptor. And so though there was concern that there might be there's a risk of drug-induced liver injury, we did not see that in the clinical trial. We also saw in the long-term extension of the phase 2 study that it has not found any new harms, and that's up to 6 months. Next slide, please. As always, there are some controversies and uncertainties in the evidence. Oveporexton was studied as monotherapy. It's uncertain whether there'll be need for combination therapy in real-world use. As we mentioned before, standard of care is generally people are on more than one drug. We also, in our network meta-analysis, were not able to test oveporexton versus current combination therapy. So we don't know what the efficacy of oveporexton is versus a combination, for example, of venlafaxine and modafinil. Combining sodium oxybate products may not capture all the unique benefits from the different forms and dosages. And there was lack of subgroup data, especially in children, which is an important subgroup because this disorder is often the onset is in children or adolescents. Next slide, please. Some benefits beyond health, special ethical priorities. The current treatments for NT1 do not address the underlying orexin deficiency that's characteristic of NT1. And so the current treatments mainly address symptoms. And so this is people with narcolepsy aren't always satisfied with this treatment. So there's a opportunity for improvement. Treatment with oveporexton is also likely to improve caregiver quality of life if the treatment allows persons living with NT1 the ability to participate more fully in their daily activities and work, et cetera. Next slide, please. As always, we appreciate public comments on our report. We heard that sodium oxybate products have differing properties, and thus combining them for the NMA was not appropriate. Again, we felt like because we are looking at efficacy, the efficacy is similar across all forms, and it was appropriate to combine. And the trials in the NMA, because of data limitations with the lower sodium form of oxybate, only included the higher sodium forms. And again, oveporexton was studied as monotherapy, and there's no evidence that NT1 patients will need combination therapy. We heard, though, from our clinical experts and from patients that this is a possibility, that they believe that some proportion of patients may need combination therapy. Next slide, please. In summary, narcolepsy is a chronic neurological disease with lifelong effects on daily life activities. Oveporexton is the first drug to address the underlying orexin deficiency that's characteristic of NT1. And treatment with oveporexton resulted in larger improvements in daytime sleepiness than the active comparator drugs. We weren't able to compare oveporexton with the active comparator drugs in cataplexy, but oveporexton itself versus placebo reduced cataplexy. Harms of oveporexton appear minimal, but longer-term studies are needed to confirm the harms. So what this brings us to, next slide, please, is our evidence ratings for oveporexton. And we have a few evidence ratings. The first one is oveporexton versus placebo. And we gave this comparison a B+ rating, which is at least a small net health benefit and possibly is substantially better. This is in part because oveporexton represents the first therapy for NT1 whose mechanism of action directly addresses the orexin pathway, and there were statistically and clinically significant improvements in the outcomes versus placebo. It's also well tolerated. However, there is uncertainty in the benefit as we don't have the publications of the trials in a peer-reviewed journal, and the outcome measures may have some precision issues. For example, the Epworth Sleepiness Scale is subjective. And then we don't have data on long-term harms. But it seems clear that despite these limitations in the data, oveporexton is likely to have benefit, and we think probably on the substantial side. over placebo. Next slide, please. For oveporexton versus active comparators, and there you see our active comparators are modafinil, venlafaxine, sodium oxybate, and pitolisant. We gave these comparisons a C++ rating, at least as good and possibly somewhat substantially better. Here, we only have indirect comparison from our network meta-analysis, and only for certain outcomes. We were only able to quantitatively evaluate ESS and MWT and qualitatively evaluate cataplexy reduction harms. So we have less certainty. We have moderate certainty about the benefit of oveporexton versus modafinil, sodium oxybate, and pitolisant, leading us to a C++ rating. That is the end of my presentation. I'm happy to take questions.
Thank you so much, Dr. Lim, for that very thorough presentation. This is the opportunity for members of the Midwest CPAC to ask questions, but I see that one of our clinical experts has his hand up. Dr. Scammell, would you like to lead us off? And then I'll go to Jill.
Yeah, sorry, I'm probably talking out of order. I just wanted to just touch on one thing that Grace said, and I think it was just a little slip. You had said the normal value for the MWT is less than 8 minutes, but I think you really meant the multiple sleep latency test is less than 8 minutes, because there's nothing in your slides that was wrong. It's just that normative MWT results are at least 20 minutes or thereabouts. And so it's important because the sleep latencies that we see on the MWT with oveporexton are in that range, are in that normal range.
Thank you, Dr. Campbell. Thank you for correcting that.
Thank you, Jill.
Thank you. Does this disorder keep you from driving, or are there in certain states, are there laws that if you get this diagnosis, you can't drive when you get to that age?
Thank you. Thanks, Jill. I will actually turn that over to our clinical experts and our patient experts who have personal experience with that. So Emily or Tammy, would you like to address that question, Jill's question?
Sure, I'm happy to chime in, and Emily, if you have anything to add. So many people choose not to pursue driving out of fear or other, restrictions that are put on them by the diagnosis. My daughter has a driver's license. She chooses not to drive. In the state of Utah, you have to have your provider fill out a form every year stating that you are on treatment and they believe that you are able to successfully complete that task of driving. Yeah, Emily, anything that you want to add?
Yeah, similar. I think the clinical experts will have more insights on how things vary state by state with what you disclose to your motor vehicle bureau, getting your driver's license. But myself and others that I've communicated with in the community, similar to Tammy's daughter, maybe place limitations on ourselves because we kind of know when we get sleepy or know how well rested we are before a drive, or pull over and take a nap when we feel like we're sleepy. But yeah, try to be conscious of how safe we are when driving.
Thank you.
Thank you,
From state.
Oh, yes, Dr. Scammell.
I was just going to add, so Jill, it really depends on the state. Because, like California has, like if somebody falls asleep driving, in California, there's mandated reporting. In Massachusetts, it's really at the discretion of the doctor. And so it's hard to answer that generally. I think overall, there's no state that prohibits it except for commercial drivers. And so, commercial driving or something that requires sustained attention is definitely off limits, which with our current meds is completely sensible because people with narcolepsy, even on meds, have a 3 to 4-fold increased risk of car accidents. And that's a testament. I think what you just heard from Emily and Tammy is that people do their best to limit themselves. And a lot of my patients say, I don't drive after 7 o'clock at night. I don't drive more than 30 minutes. I always drive with a friend, and so people come up with strategies that allow them to generally drive. But even with that, stuff happens.
Thank you all. That's very, very helpful. Eva?
Yeah, just a quick question to the certainty ratings now that I've looked at it again after reading it, and also, had the confidence interval sink in a little bit. So not entirely sure I understand why you say it's a possibility that there could be a small effect. To me, it all looks large. The confidence intervals really don't go into a small effect. And yes, it's a net effect. So presumably there's eating in with some of the harms. I did not see those harms. Believe me, I'm very sensitive to harms. I'm a hepatologist. But, unless I see some data that it's really clinically relevant. At this point, it doesn't eat into my benefit. So I would just like to hear one more time the justification that this could include a small benefit. Thank you.
Sure. Thank you for that question. Actually, Dr. Ortiz, did you have a comment on that question?
Yeah, actually, Dr. Scanlon and I had discussed this during an earlier meeting. It's like with results like this is like amazing. Why not it being an A plus? But I have a handful of patients, they respond beautifully to some of these older medications or the current medications and they've been doing fantastic for years. And someone thinking about like what if they've been doing so well and fantastic on what's already available, why would I change them? And so like, yeah, they would be probably minimal to similar benefit to what they're already on already. But granted, these are just a small handful. And so like with thinking about it and kind of going over the presentation today, it's a range. And I think most people, like if you're looking on an individual to individual basis, they're probably going to be B plus to A, but there's always going to be a handful where they may not have benefits or much more benefits than what they're already on, but those are going to be the minority, in my opinion.
Thank you, Dr. Ortiz. Yeah, and I would say some of this has to do with certainty. So particularly for the active comparators, all of our comparisons are indirect. We do not have any direct data comparing oveporexton to therapy, to the currently available therapies. And as Dr. Ortiz said, I mean, some people do well on the current therapies. So, and the current, in our NMA, we weren't able to test combinations. So most people are on combination therapy. So we're doing, oveporexton monotherapy versus combination therapy. So those are just some of the uncertainties that we had that pushed us towards the B plus rating, allowing for a small net health benefit. Rachel and Dr. Scam, I'm sure Dr. Scam, are you wanting to respond to this question?
Yeah, no, it has to do with what Louis said. And I agree that there's some people who come into clinic and say, oh, I'm doing fine on modafinil or something like that. But then sometimes when you scratch below the surface, their Epworth score is still elevated, at maybe 12 or something like this. They're getting by okay. But I think one of the things is when people live with this for years, they don't know they don't even remember what it's like to feel normal. And they just are used to basically working around their narcolepsy and sure, they're doing their job, they're getting home, but their quality of life can still be limited. They're not eager to switch to more aggressive medicines, but I would argue that even some of those people who say they're doing okay could do better.
Eric?
Was the duration of benefit related to, was the duration of benefit, did it contribute to your B plus rating rather than your A? Like, I understand the difference, the comparators. I think this study's about a comparison to a placebo and not necessarily, I don't think the B plus rating to me has to do with its incremental uncertainty over another drug. I kind of agree with Dr. Scammell, which is like, people may not want to change meds because they don't know what they don't know, but or the risk isn't worth it. But to what extent was duration or durability of the benefit part of the rate, your assessment of the rate?
That's a great question. Thank you, Eric. Yeah, that definitely played in. So these trials are 12 weeks long. I think, so they're very short. You do see a tremendous effect, but we know from other narcolepsy treatments that sometimes durability can wane over time. And we don't know that here with oveporexton. The longest follow-up we have is 6 months, and this is obviously a lifelong disorder. So, there's uncertainty there as well.
So I would just say, like, when I was looking at the rating, that was my primary kind of reason to agree with the score you gave it. It had to do with durability of benefit, not the demonstrated incremental value in the trials. So,
thank you.
for whatever that's worth.
I am interested in learning more about this question of polypharmacy and combination therapy. And so, Dr. Lin, I know you told us that the clinical trials were compared to placebo, even though polypharmacy is common. I'd love to hear more about what we know about that. Emily and Tammy, any insights you might have about what some of these treatment regimens are like in practice? And then also to our clinical experts, is there a sort of standard of care against which, right, you might have envisioned running these trials, and how might you think about some of the meta-analysis in that context?
Sure, thank you for that question. I would say the majority of people that I talk to are not on a single therapy. There are a few, sure, but some of that is also because they are seeing a doctor that isn't comfortable prescribing medications for them to reduce additional symptoms. So we get a lot of people that come with that are on one medication, a stimulant, and their doctor won't pursue additional therapies to help them. I spend a lot of time with those individuals and helping them to get better therapy for their symptoms. But the majority that are, to Dr. Scammel's point, that we would consider that are doing well are on multiple medications. My daughter is on at least 4 medications to manage all of her symptoms.
I would add that a principal driver of polypharmacy is the constellation of symptoms and, impacting your entire, 24-hour sleep-wake cycle. So most people who are on optimal, which I don't think ever really means like feeling 100%, but optimal therapy are who have narcolepsy and cataplexy are probably taking a nighttime drug and then something in the daytime to stay awake, unless the daytime meds, are introducing challenging tolerability issues, and then they're kind of functioning on like lifestyle modifications and naps to make it through the day.
Thank you. These themes of access to care, to specialist care, seem to be particularly important. Either of the clinical experts, is there something you'd like to add on this topic? And then we'll go to Brett.
Yeah. So, the American Academy of Sleep Medicine does have a set of guidelines towards the treatment of narcolepsy. And the most recent guidelines, while they're already out of date, and they will be out of date once oveporexton is approved, they do try to tackle it based on factors such as excessive daytime sleepiness, cataplexy, disease severity, and quality of life, with their own review as to how adequate these medications tackle it. And as a clinician, and I do kind of I try to break down the narcolepsy symptoms and try to pair that with a medication that would be appropriate. So, for example, if they're complaining about a lot of disrupted nighttime sleep, that's leaning me towards an oxybate product. However, oftentimes that's not going to be enough to take care of the excessive daytime sleepiness. And so they're also going to have something specific for excessive daytime sleepiness. And then depending on if they have cataplexy or not, or how severe the cataplexy is, that may guide me towards a medication that does excessive daytime sleepiness and cataplexy. And if that's still not enough, then we got to start looking at things specific for cataplexy. And so it's almost, I tell my patients, it's a bespoke process for each patient. Everyone's going to be a little bit different. Everyone's complaints about the specific factors of narcolepsy is going to be a little bit different. Everyone is going to complain about, the number one is always going to be the excessive daytime sleepiness, but it's a lot of the other symptoms that color their experience that we need to tailor their care for.
Thank you. Brad?
Yeah, this could be kind of a similar question. I'd like to hear from the clinical experts, and I know we don't have the evidence base to compare the polypharmacy, benafidil and venlafaxine and other combinations. We just saw the network meta-analysis results. They were pretty impressive, but they were all compared to single agents. About how much do you think we might be overshooting the potential gain with this new therapy compared to those existing what seems to be widely used combination therapies?
I can take that one. So, as you heard, the majority of patients are on multiple different drugs. And I would say with the addition of drugs, we get small incremental benefits. The effects are not additive. And so, for instance, if you're using an oxybate at night, yeah, you'll get a little bit more alertness during the day by adding on modafinil, but it's rare for it to really make a big difference. And so, and also, if you look at even just the magnitude of benefits with the current medicines, it's a few minutes. It's like 2 or 3 minutes on the MWT compared to, effects that are 4 to 5 times larger with oveporexton. So I think that it's very rare for us to have patients who come in and, we typically measure the Epworth Sleepiness Scale. We don't measure the MWT in routine clinical practice, but it's quite common that somebody will be on 3 or 4 meds and they'll still have an Epworth score of 11 or 12, which is not in the normal range. And they say, well, I'm getting by. And I'm sort of like, yep, well, we can't really do much more. We've already tried you on a bunch of different stuff. And just to touch on Rachel's thing too, with polypharmacy comes more side effects too. And so, sometimes people end up living with some anxiety from their amphetamine. They're getting up to pee from their oxybate. Maybe their modafinil gives them a headache. And so, they're just, but, they say, well, I gotta work. And so they're just putting up with some of this stuff.
We now have a robust queue from the Midwest CPAC. So, Reem.
I was just going to highlight the side effects issue, which these are not benign medications with no side effects. So I think even to me, even if the impact was comparable to multi-medication, the side effect will make the balance tip in one direction. Thanks.
Jimmy?
I just wanted to piggyback of what Dr. Scammell said earlier on in regards to the, when patients live with a lifelong illness like narcolepsy, it becomes, you tend to learn how to cope with it. And particularly because it's an invincible disease. I don't know if the value framework in any way underestimates that there are patients who might not show the data that they are going through serious symptoms and have just come up with coping mechanisms to live with the disease and on the surface look completely okay. Meanwhile, they're essentially suffering.
This, I think, is where it gets into the softer endpoints that are hard to measure, right? Can somebody because we often focus a lot upon whether somebody can stay awake in their classes or whether they can hold their job, whether they can do their commute. But I think, as you say, there's a lot of things that people give up. It's like, if you're only limited to driving 30 minutes, that really cuts off a lot of options. If you can't stay awake at night because your meds are wearing off, you can't play Legos with your kids. So I think as it is right now, and I think it'd be good to hear from Tammy and others about this. I just feel like people are getting by, but I don't feel like they're really living the fullest lives they can.
If you don't mind if I jump in on that, since the call out, Wake Up Narcolepsy has 10 weekly support groups, online support groups. And so there's a support group available every day of the week and several on some of those days. The support groups are full of individuals every week that are addressing these very topics that Dr. Scammell mentioned. The not being able to do the things that are outside of the minimum. I have to go to school. I have to work. I have to, care for my family. But what else? And many times it's a decision between which I can do. Can I go to school or can I work? I can't do both. And so that is a really hard thing to put down into this score.
Yes,
Thank
having
you.
been on the trial, I think that having more patients exposed to this medication is actually going to give us more words for describing our symptoms because for me, having a very distant memory of what it was like to live without narcolepsy, and then to, have my orexin signaling restored, like my receptors were just there waiting, and to see it was more than just like being more awake. It was like a level of attentiveness and focus. My family told me that my mood was better. And so it was just, and I guess maybe we're grumpy when we're sleepy, but there was just also a greater like mindfulness and presence of the world around me. And it was so funny to like be getting on the freeway and notice that like I wasn't sleepy because that had become my normal. Like, how sleepy am I? Instead, it was just like, this is so weird. An absence of sleepiness. I'm all the way awake. So I think that's going to be a really different experience than we get with any of the medications that are available. And we'll notice the other symptoms that are like, oh, that was related to my narcolepsy. Like I was like, okay, I'm not lazy and unmotivated. I just need my orexins to be working.
So this is a terrific discussion and very rich and detailed, but unfortunately it's time for us to move on to the presentation of the economic model. So I'd like to introduce Linda Liu, research scientist at the University of Washington. Linda, would you take us through the economic model, please?
Thank you, Sarah. I'm sorry, Rachel. Um, Next slide, please. So on the economics team, we have Josh Carlson and Hui-Shen Chan from the University of Washington, as well as Woo-Jung Lee and Marie Phillips from ICER. For disclosures, the University of Washington does receive financial support from ICER, and Josh Carlson has received consulting fees from Takeda, however, not related to narcolepsy. Next slide, please. So the objective of our model is to evaluate the lifetime cost effectiveness of oveporexton compared to a combination therapy of modafinil with venlafaxine, sodium oxybate, pitolisant, and no pharmacological treatment for the treatment of narcolepsy type 1 in adults. Next slide, please. So before getting into the model, I want to first highlight the unmet need that exists for our population despite the currently available treatments. So the expected shortfall values displayed here are calculated using a modafinil and venlafaxine combination treatment as reference for our modeled population, which is the adult narcolepsy type 1 patients with a mean age of 30. So even with treatment, patients are expected to lose about 10.4 remaining equal value life years, which is about 25% of the remaining life expectancy when each year is valued equally regardless of health state. So to put this in perspective, in regards to other conditions, the unmet need for narcolepsy type 1 is most comparable to hemophilia, higher than osteoporosis, but lower than multiple sclerosis. So together, hopefully these figures show that there still exists a substantial burden of disease despite the current standard, the current treatments, and presents the unmet need that a new treatment such as oveporexton has the opportunity to address. Next slide, please. So moving on to the methods used in the model, we used a standard ICER approach of a Markov model set in the United States with a lifetime horizon and 3-month cycle length. Next slide, please. Our model consists of 3 health states. Patients enter in an initial treatment, and those who discontinue will transition to a subsequent treatment. From either of these 2 treatment states, patients can transition to death. We did 2 different analyses structured around the best available data for each comparison. So in the first, we compared oveporexton to the active comparators, and in this subsequent treatment consisted of a weighted basket of the comparator treatments. And then in a separate analysis, we compared oveporexton to no pharmacologic treatment, where oveporexton discontinuers moved to no treatment instead of the subsequent basket. Patients who started on no treatment remained on no treatment throughout the model. Within the initial and subsequent treatment states, patients are classified as responders or non-responders. This response status drives non-drug costs, but utilities are treatment-based and independent of response. Next slide, please. Our model cohort is based on the patient population in the placebo and 2 mg twice daily arms of the phase 3 oveporexton trials, First Light and Radiant Light. So they have a mean age of 30 with slightly over 50% female and an Epworth Sleepiness Scale or ESS score of 18.1 that falls into the severe EDS categorization. Next slide, please. So some key assumptions we made in the model was first, we assumed treatment effectiveness remained constant over the lifetime. And this was due to limited long-term data on treatment effects. Second, we assumed patients who discontinue initial treatment move to the subsequent treatment basket. As Grace noted, and as in the conversations we heard earlier, polypharmacy and treatment switching are quite common in practice. Unfortunately, there's no robust evidence to inform specific switching patterns. And third, due to no clinical trials on combination treatments, we had to assume that venlafaxine only affects cataplexy, and thus only the cost in the model, while modafinil affects excessive daytime sleepiness, or EDS, and drives the changes in health-related quality of life. So this assumption is supported by literature on health-related quality of life in narcolepsy that identifies sleepiness as a significant driver in utility changes, but not cataplexy. Next slide, please. So fourth, we assume patients achieving response have no excessive daytime sleepiness and incur non-drug and productivity costs equal to controls without narcolepsy. So we expect healthcare use and productivity to improve as excessive daytime sleepiness resolves. However, there isn't sufficient evidence to model costs at a more granular level. And then finally, due to insufficient evidence on treatment impacts on mortality, we assume treatments had no impact on mortality in the base case. Next slide, please. So responders in the model are defined as patients who achieve ESS scores of 10 or lower, meeting the no excessive daytime sleepiness categorization, and non-responders are patients with a score greater than 10 and can fall within mild to severe excessive daytime sleepiness. So the table shows responder rates by treatment. These are sourced from the ICER NMA, and the responder rate for sodium oxybate is pulled directly from the rest on trial due to it not having a placebo percent to include in our NMA. Next slide, please. So we had two components for discontinuation, adverse events and lack of efficacy. The table shows 3-month discontinuation rates for all treatments. Rates applied for the first cycle were obtained from the respective treatment short-term trials, and rates from the second cycle up to 2 years were obtained from the long-term extension trials for these treatments. After 2 years, we assumed all treatments had the same discontinuation rates due to insufficient data. We applied the rates observed in Harmony 3 as it had the longest follow-up of 5 years. Next slide, please. Our subsequent treatment approach was informed by stakeholder input. The subsequent treatment basket is a weighted mix of all available therapies shown in the table, with weights drawn by survey data by Dr. Ortiz. The same basket composition is used regardless of which treatment a patient discontinued from. So this includes allowing patients to re-enter the treatment that they had just discontinued. Since in practice, patients could return to a prior therapy, whether at a different dose or after trialing alternatives. Additionally, a given therapy is assumed to have the same efficacy whether received as initial or subsequent treatment. Next slide, please. So price for oveporexton is currently not available. Because of this, we used an annual placeholder price of $250,000 based on estimates from IPD Analytics. When we get into the results, please keep in mind that these results will be based on this placeholder price. And the table shows the wholesale acquisition costs as well as the net annual costs for all treatments used in the model. For the base case, we use the generic version of sodium oxybate at the price and dose shown here. We then ran 2 scenarios to explore real-world variation, one varying the dosing assumption for sodium oxybate and one using the distribution across all sodium oxybate products. Next slide, please. So annual non-drug and productivity costs were stratified by response status. Both cost inputs were sourced from DONE 2025, with non-responder costs drawn from the narcolepsy population and responder costs from the matched control population, reflecting an assumption that effectively treated patients incur costs more similar to individuals without persistent excessive daytime sleepiness symptoms than to symptomatic narcolepsy patients. Productivity costs were applied only in the modified societal perspective scenario. Next slide, please. So our base case utilities start from USH-based general population utilities, scaled using a narcolepsy type 1 specific multiplier for patients on no treatment. This approach preserves the natural age-related decline in utility while reflecting the disease-specific decrement for untreated narcolepsy type 1. So the utilities shown in the table here are for baseline, so age 30 patients. And then on top of this baseline, we applied treatment-specific utility increments drawn from the pivotal trials to obtain values, treatment-specific values shown in the table. As Grace mentioned, narcolepsy has multiple dimensions. So in using utilities measured directly in trials, we hope to indirectly capture as many dimensions of disease as possible. One con of this approach is that different treatments use different health-related quality of life instruments, and that can introduce some uncertainty in their comparisons. So in a scenario, we used ESS-based utilities from Cranbourne-Millot, with treatment effects translated into utility differences based on change in ESS that was sourced from our ICER NMA. Next slide, please. The base case applies all cause, age, and sex-specific mortality from US life tables, with elevated mortality from narcolepsy applied uniformly across all treatments. We explored uncertainty around these mortality assumptions in scenario analyses where we removed excess mortality either from just responders or from all patients. Next slide, please. So moving on to the results. I just want to flag that there have been some revisions to the intervention acquisition cost since the report. Results in this table will be a little different than in the report that we had posted, but has been updated in the evidence summaries and will be updated in our final evidence report. So in the Overprextin to active comparators analysis, Overprextin delivers approximately 2.8 additional quality adjusted life years and equal value life years over the best performing active comparator, although utilities across comparators are very similar within 0.09 quality adjusted life years of each other. Due to our mortality assumptions, there's no difference in life years across treatments, so quality adjusted life years and equal value life years are equal. And Overprextin's total cost is driven primarily by the intervention acquisition cost at the placeholder price of $250,000 annually. Next slide, please. So Overprextin does not meet any common cost effectiveness thresholds, with cost effectiveness ratios ranging between 470 and 1.2 million at the placeholder price. Next slide, please. In the comparison against no pharmacologic treatment, structure, so patients who discontinue Overprextin move to no treatment instead of the treatment basket. Overprextin delivers about 3.1 additional quality adjusted and equal value life years over no treatment. This is a larger gain than we saw against the active comparators due to it being untreated disease. The slide also shows cataplexy attacks. Overprextin is estimated to reduce lifetime cataplexy events by roughly 16,700 attacks, or 42%, when assuming a constant weekly cataplexy rate from that observed in the phase 3 trials. So incremental cost effectiveness ratios for Overprextin compared to no treatment are estimated to be around 1.2 million at the placeholder price. Next slide, please. We did a one-way sensitivity analysis to examine the impact varying individual parameters had on results. This graph is for modafinil and venlafaxine, but similar results are observed for the other comparators. We found that the incremental utility for Overprextin had the largest impact, with responder proportions and non-drug costs showing moderate impacts. Even at the extreme values, the cost-effectiveness ratios did not meet cost-effectiveness at the assumed placeholder price. Next slide, please. We also varied all parameters across 1,000 simulations, and in no simulations was Overprextin cost-effective at the placeholder price. Next slide, please. We conducted 7 different scenario analyses shown here. Most scenarios did not have large impacts on our results, with cost effectiveness ratios staying within 10% of the base case. Next slide, please. The one scenario that had large impacts was one where we use ESS-based utilities. It roughly doubled to tripled our incremental cost effectiveness ratios compared to the base case when using the placeholder price. Next slide, please. So the estimated annual price for oveporexton to meet common cost effectiveness thresholds of $100,000 and $150,000 annually when compared to modafinil and venlafaxine are shown here. This was chosen to be our main comparator as we heard it was the common first-line agent and generic option combination. Next slide, please. So some limitations in our model include uncertainty introduced by the utilities. Treatment-specific utilities used in this case were derived from trials that use different instruments, which may respond differently to the same clinical change. Additionally, our scenario and one-way sensitivity analyses highlighted the large impacts utilities have on our model's results. A second limitation was that there's insufficient data to model long-term impacts, such as those on cardiovascular health. Some of these may have been indirectly captured through our non-drug cost and trial-based utilities. However, not fully capturing these elements likely underestimates disease burden and the benefit of treatment. And then finally, differing protocols across trials and lack of trials and combination treatments also introduce uncertainty in our comparator effectiveness. Next slide, please. So from our draft report, there have been some changes based on the comments received as well as updated data. So our placeholder price changed from $175,000 to $250,000 based on new estimates from IPD Analytics. Additionally, we added the scenario analyses for sodium oxybate and expanded our uncertainties and controversy sections to address our framing for no treatment, as well as the potential unmodeled disease burden. Next slide, please. So in conclusion, oveporexton showed meaningful clinical benefit with gains in quality adjusted life years and eco-value life years relative to all comparators. At the placeholder price of $250,000, it exceeds commonly cited cost effectiveness thresholds across all comparisons. However, the cost effectiveness for this treatment will ultimately depend on the final price. Next slide, please. And with that, we are happy to take any questions.
Thank you very much, Linda, for that very detailed presentation. So CPAC members do now have the opportunity to ask questions. I see one from someone who's having difficulty with audio, and maybe I will read it out and we can begin with that one. There's a question, right, about aging, and the question is about whether at a later age people may achieve remission or lower frequency of cataplexy and hypersomnolence, and how this might relate to the question of long-term value. That's the first question we have in the chat. Linda?
You want me to take that one?
Oh, yes, that would be very
want to
helpful.
refer to the clinical experts. We did not model this type of age effect. We did not have evidence to look at this type of an age effect, but happy to defer to the clinical experts for that aspect.
So the short answer is we don't have good data on this. There's no longitudinal studies following the same individuals across their lifespan. Just anecdotally, the sleepiness can be super intense in teenagers. Probably somewhat less in middle years. And then when people are retired, they can take naps, but they're not working anymore either. And so it's easy to slot it into their lifestyle. Cataplexy also tends to be super intense when the disease first develops in the teen years, but it can persist at a pretty solid level. But unfortunately, we don't have that. Nobody's ever measured this. This is just essentially clinical observation.
That's very helpful. And then a second question that we also have in the chat is a question about whether is a possibility or a probability of incapacitating injury for some type 1 patients from things like a driving accident or a catastrophic fall, and whether that may have been included in the analysis.
So I can take that first. We don't have that directly in the analysis. It's possible to be capturing that indirectly because when patients are responders, we have health-related resource use estimates that drop to basically people without narcolepsy level, and so those would be assumed to be captured there. We don't have very good evidence of that. We did hear from stakeholders this is a potential issue, but we also heard that patients often cope, and as we perhaps drive less or do things to try and avoid some of these things as well. So again, not directly captured, possibly indirectly captured through the way that we're doing health-related resource use estimates and responders.
Thank you, Josh. Dr. Scammell, you wanted to weigh in on this, and then we'll go to Tim.
Yeah, I had a question for Linda about the cardiovascular stuff. It's something that's gotten more attention over the last 5 years or so. We know that there's a much higher prevalence of hypertension amongst people with narcolepsy type 1. And to make things worse, most of the meds that we currently give them probably contribute to this. Amphetamines, solriamfetol, even antidepressants, and certainly the high sodium oxybate, which is a ton of sodium. It's your whole U.S. daily dose of sodium. And so I guess I think that may be important because I think you showed that the Ohayon study showed increased mortality. We don't really know where that comes from, but I think I don't know if it's possible to include sort of that cardiovascular angle this late in the game.
Yeah, we haven't seen any data on it. Interestingly, there was a study recently published at the end of 2025 that showed that there wasn't additional mortality due to narcolepsy in matched controls in I think Taiwan. So I found that quite interesting that there might be like some uncertainty around mortality for disease, and then there is no direct evidence for any treatment impact on these long-term outcomes. So we weren't able to model any of these.
We did have, slightly higher mortality for everyone, and so it could be captured as part of that elevated mortality without it specifically being associated with the cardiovascular component of that mortality. Again, we don't have direct impacts from the treatments on that either, so the incremental impact would also be attenuated in that situation.
Thank you. Tim?
Yeah, great work as usual, Linda and Josh and others. And given the results that are sort of overwhelming, there may not really matter. And Don's question was great, but I just sort of want to see if I can put a, final point on it. I think we heard in the clinical evidence that there are no long-term impacts or not many long-term impact results from those. How much did that play into your findings, or is it looked like the incremental utility was really driving everything?
I can start and Linda can chime in. So we actually maintain the treatment impacts long term. So we didn't have a lack of efficacy over time or a waning. The only thing that sort of happened over time was some discontinuation, which does happen. That takes people coming off. But so we actually didn't ding the products for any sort of long-term attenuation in the effect. So that did not come up.
Emily, I'd love to hear your perspective. I'm sorry, you're still muted.
Emily, you're still muted.
Still on mute.
Oh, sorry. I would be changing the topic, a question that I have. So if you want to finish on the current topic, go ahead.
No, I think we're ready.
Okay. Yeah, I mean, so much of like these life year value, et cetera, calculations are over my head, but I did want to comment because there was the one portion where you referenced data for excessive daytime sleepiness having an impact on health-related quality of life. but not cataplexy. And so just from the patient perspective, I want to make sure it's emphasized that cataplexy absolutely has an impact on quality of life, and untreated cataplexy. I mean, I'm one person, but for me, makes it so that I can't participate in certain sports. I can't, I probably would limit my driving even more. I would probably wouldn't be able to ride a bicycle. And even when I'm treated optimally, like I don't ever dread time with my family, but my siblings are my biggest triggers for cataplexy. And I feel like the older I get and the older like my nieces and nephews get, for them to see me incapacitated is just like so embarrassing. And so I didn't want to discount experientially the impact on quality of life that cataplexy has.
Thank you, Emily.
Thank you.
I'm
And we'll
not.
just know we
Oh.
did use general health related quality of life measures, which would actually capture that component. The specific note was just related to one of the assumptions and the use of combination treatments, and that the primary sort of statistical evidence on that measure was related to the sleepiness part, not the cataplexy part. But the actual utility differences that we use will hopefully be capturing impacts from ES, from daily sleepiness, cataplexy, all of it, because it's a general health related quality of life tool.
Okay.
And we did certainly hear from yourselves and other patients that cataplexy is a big component of the disease.
Thanks for that
If
explanation.
I could just also add to that, potentially the impact on that, on the assumption, is we may have underestimated the benefits of modafinil and venlafaxine, but not the treatment. So because we didn't have data to be able to capture what the venlafaxine does, we just use modafinil.
So I have a question that's related to the presentation of the model, but it invites maybe the patient and the clinical experts to weigh in on some of these costs. So we see in the economic model the cost of the relevant comparators, and some of them are, we might say, very inexpensive relative to others, right? Modafinil and venlafaxine are certainly much less expensive on an annual basis than sodium oxybate or pitolisant. And so I was hoping to hear from both the patient advocates on how patients experience the cost of these medicines, and then also from the clinical experts on access to care, right? And things like prior authorization and whether patients are able to actually get treated on these products.
Great question. I think we're looking at monotherapy, right? So if you take all of the medications that an individual living with narcolepsy may be on, it's a greater cost than we're assuming with one medication. And that certainly when I was introduced to the costs of some of these medications, I was blown away. As I see these numbers now, I'm kind of used to that is where our medications fall. Certainly, there are barriers to access because of the cost of medication. I think our pharmaceutical industry does a good job of providing access through other means, coupons, patient assistance programs to allow patients to access those medications. I think we have a struggle with insurance approvals, certainly, and we do have many people that are struggling through that process, how to get the medications, and not understanding the process and getting derailed along that process. So maybe that's a topic for later. But I think it would be interesting, and I'd like to, maybe there's another spot for this as well, but the burden of getting some of the medications that currently exist, I would say stimulants are one of the hardest for a patient burden to get. So the cost may be lower, but getting it on time at the pharmacy, consistently being able to fulfill your prescription, it might be a low cost, but it's a high burden for patients.
Yeah, I would suggest that there is a disparity that is experienced in the community as far as being in a position to have adequate insurance coverage that, for instance, qualifies you for what patient assistance might be offered by the pharmaceutical company. Like I'm very reliant, for instance, on my husband working for a company that enables us to have commercial insurance. And I think what we see in the community is people getting stuck in this cycle because you have to be working to have employment to have insurance in order to cover the meds. And if you don't have meds, you can't become employed. And then even having commercial insurance, I only kind of figured out the prior authorization process and like my role in it, in like assisting my physician's office to expedite it in order to get access to the medications that will be the most helpful to me. I feel like I only wrapped my mind around that like within the last year. And who has time if they're tired and trying to maintain employment to jump through all those hoops? So I think these are some of the barriers that much of the patient population run into.
Bijan?
Yeah, thank you, by the way, Linda. That's a very good presentation. I have a question that maybe a little bit technical. So the way there is an sort of initial treatment and subsequent treatment, right? And the way I understood the model is that for oveporexton, they would be in the initial treatment group, and then in terms of comparing to the comparators, I mean, some of them might be moving in the subsequent stage to any of the comparators. And this comparison kind of happens over time, over the lifetime, correct? Now the question is how exactly, so because remember some of those say comparator one, like they might move to comparator two, like in the next subsequent stage. I guess that part I didn't get essentially, when you compare oveporexton to like say any of the comparators, because remember they in the subsequent stage they may not be in the comparator that you started with. So how exactly the model is doing that comparison?
Yeah, that's a good question. There it can get really complicated for like patients tend like we've heard that in practice patients tend to switch treatments quite often or that they want to try a lot of different treatments. It's also the polypharm. So this was kind of like a simplifying assumption, and it's our way of like best capturing this was just to put them on a basket based on what we saw was in use in the real world based on survey data. So when patients discontinue, they're distributed into a basket of like current treatments. So even if there was switching after the first discontinuation within that, some of that could possibly be captured, but it's definitely a simplifying assumption.
And it's also a population, so it's the distribution that we're capturing. We're not capturing individual patient trajectories. So you can think about it as being a steady state that we're assuming has the distribution that we observe in actual practice, and that once they're off the initial treatment, there's sort of a steady state of treatments that people are on, and that we're just sort of have a distribution that patients can be at any given time.
So in essence, the comparison is essentially with oveporexton with the distribution of the rest of the basket, right?
So the initial treatments, it focuses the comparison on the initial treatments because they get one, everybody starts on one. Okay, so that's where most of the action is. And then once they discontinue, everyone goes to sort of a similar health state, so that this keeps the emphasis on that initial comparison rather than what we assume happens sort of long term and all these different possible sequences that might happen.
Okay. Thank you.
Mm-hmm.